Greetings. My name is Dominic McDonald. I'm a current second-year MBA student, and I first wanted to thank you for making it with us throughout the whole entire day and sticking with us to the last panel. I'm very excited to be welcoming you to the Healthcare Innovations panel, and we have a great lineup of panelists to be speaking with you today. So now I'm going to introduce Dr. David Bangsberg, who will help me with moderating this panel. Thank you.
Hello, everyone. Thank you for coming. Today's panel is around innovation in sub-Saharan Africa, and whether the explosion in innovation is really hope in terms of we can deliver better care to more people more efficiently and effectively, or whether it's a distraction, and whether there's a lot of hype and we're missing the ball and not focusing on the ground issues in terms of improving access to care. We have a great panel today, which includes, to my left, Patrick Lukulé, Vice President of USP's Global Health Impact Program, Joya Mukherjee, the Chief Medical Officer of Partners in Health, Bill Rodriguez, the Chief Executive Officer of Doctari Diagnostics, Elizabeth Bailey, the Director of Camtech, and Janine Uzel, the Director of Healthcare Programs Africa at GE Global Growth and Operations. The format of today's panel will be, we'll have each of our panelists spend 3 to 5 minutes talking about their views on technology innovation in Africa. And then we'll open it up to questions for the audience to really engage in a dialogue about where they see technology innovation headed and what the potential impact might be. So with no further ado, so we can get to our discussion, I will let Patrick start our discussion.
Good afternoon, everyone, and I want to add my voice to the chairman's voice of welcoming you and expressing our appreciation that you stayed behind to listen to our discussion. So I'm Patrick Lukulé. I'm the Vice President of United States Pharmacopoeia and Director of a USAID-funded project that oversees improving drug quality in several countries around the world, about 35 countries or so. United States Pharmacopoeia, I am sure most of you may not have heard of it, but it's a very important institution. It's close to 200 years old. It is the institution that sets quality standards for all pharmaceutical products sold, manufactured, and imported into the United States. Their standards are used by the U.S. Food and Drug Administration to give market authorization to pharmaceutical products in the United States. So it's a very important institution. But today, I'm not going to talk about USP's core functions, which is setting quality standards. Instead, I'm going to talk about some of the initiatives that USP has engaged in to improve drug quality in developing nations in Africa, in Southeast Asia, and in Latin America. I want to open up my remarks by making this very clear and succinct statement, and that is, in healthcare, quality is a must. In healthcare, you're dealing with the lives of people, and therefore, anyone engaged in healthcare practice, you have to engage from the point of view of having quality services and quality product. Why do I say that? I say that because one of the biggest threats to health systems, particularly in Africa, is the lack of access to quality-assured medicines. And I'm going to emphasize quality-assured medicines. For a very long time, development partners and donor organizations have focused on providing commodities to Africa. There is a lot of commodities in terms of pharmaceutical products, in terms of medical devices, etc., but the emphasis has never been placed on what is the quality of those products that are being sent to those countries. And so my organization has been engaged in trying to improve and strengthen quality assurance and quality control institutions within the regulatory authorities so that the products that are coming to those countries are of assured quality. Without quality, you cannot have the health outcome that is desired, that the patient deserves. And so we take that to be very serious when the business of setting standards. There should be no double standards. The same quality of medicines that are used in Europe and the United States have to be the same quality of medicines that you might use in Zaire or Congo or in Peru or Argentina, etc. And so we have started this program to try and strengthen quality assurance systems and quality control mechanisms to make sure that the pharmaceutical products that are going into developing countries are of assured quality and there can be no compromise around that. So I'm going to end there so I give opportunity to the rest and then I'll hope to follow up some more. Thank you.
Thank you, Patrick. Joya?
Thank you. Thank you all for being here, and what an awesome view that we get to see that you don't get to see. Sorry you have to look this way. I'll just talk also very briefly so we can have a discussion about sort of my organization, Partners in Health, and I think what I could say would be our view on innovation, taking up a bit David's challenge of is it real, is it important, or should we be focusing on delivery? We're an organization that focuses most of our effort on delivering healthcare. We work in 11 countries around the world and have a staff of 15,000, the majority of whom are local nationals, Haitians working in Haiti, Rwandans working in Rwanda, 85% of whom are local to those communities. The non-local people who are from the countries often are from capital cities, the physicians, the nurses, et cetera. But many of our staff are community health workers, are local people who are cleaners or drivers. And so we have a very large program and probably are not known for innovation in a technologic sense. Yet I would say innovation for us is absolutely critical. So while we are sort of mostly a delivery organization, I believe that for any silver bullet, that it's only as good as having a delivery platform. And so for us, we've been able to take something that's relatively innovative, probably not here at MIT, but in a place like rural Malawi, GPS devices, put them in the hands of community health workers and map out epidemics, local epidemics of typhoid, or areas where there's lack of clean water, where we need to put water for a cholera during a cholera epidemic in Haiti, or areas where women who are pregnant have really almost no access to care, and we may have to put a health post to do antenatal care and really administer a tetanus vaccine, et cetera. So I think for us, they're both absolutely necessary to leapfrog over the enormous gap we have in healthcare delivery, but that we focus really on creating a platform that goes from community to health center to hospital. So I would say, one, technology necessary, you need a platform. Two, I would say that for us, using innovative technology also means building real capacity. So all of the technologies we have, from something like a CAT scan, which doesn't, again, seem like big technology here at MIT, but for Haiti, the entire country had only one CAT scanner and it wasn't in the public sector. We now have a CAT scan in the public sector, but we have nobody who can read it. We have nobody who can service it. So we have to actually then build the capacity locally to kind of take care and shepherd those innovations. So I think, one, the platform, two, building the capacity, and then three, how you're going to use it in a package of care delivery. Because I think often an innovation kind of falls from the sky vertically, and if you don't have it in a platform, and the thing that I think most about this is the terrible report card the world has in preventing death from childbirth. And the reason is there is no one single technology. It's important to have GPS devices to map where women are coming from, but if you don't have access to an operating room and safe blood supply, you're not going to be able to save that woman's life. So everything we do, we have to look at in the spectrum of value chain of care delivery, from really getting to the most vulnerable in the farthest reaches, which really just takes shoe leather, can be helped by technology, two, to providing the capacity to do the right thing, and then three, putting it all in a system that will deliver care. So we look at innovation in all of those areas of how you do innovation in delivery, innovation in capacity, and how innovation can fit in a larger platform of care. And so I'll just stop there and pass it to Bill.
Good afternoon, everyone. So first, I actually want to thank Dominic for putting this panel together. This is, I think, the third or maybe fourth time I've been asked to be at this conference on a healthcare panel. And I think healthcare isn't always the sexiest topic when you're talking at a business conference focused on Africa, but I think Dominic did a great job pulling a really impressive group of colleagues together. So it's a real privilege for me to be here. I'll just give you a little background on Daktari Diagnostics and why we do what we do, and then make two observations relevant to David's question about technology innovation in healthcare focused on Africa. So like Joy, my background is I'm trained as a physician and practice medicine, and then from 2001 to 2007, I was at the Clinton Foundation working primarily in Africa, but worldwide. And really the program that we focused the most on was how do you develop sustainable business models for the important commodities that are needed to improve the quality of healthcare in Africa: drugs, diagnostics, vaccines, medical consumables, medical devices. And the challenge there is you really have to figure out how can you make it a win for the company to have make profit, have a sustainable profit, but also make it a win for the government that's delivering healthcare to its citizens through the public health system, and make it a win for patients, because after all, what you're talking about is people who are sick and need interventions that can allow them to pursue their lives and pursue happiness. And we learned a lot about how you could develop sustainable business models that could deliver HIV medications from companies to patients, TB diagnostics, TB medications, started looking at other diseases, non-communicable diseases. And I think the landscape changed quite a bit in Africa for some of those critical diseases over the past decade. We also learned that there are major gaps in the product portfolio, that we didn't have some pretty critical products that we need, like a vaccine for TB, for instance, or low-cost, effective cancer treatments, or medical devices like CAT scans that can be made affordable and easy to repair. And so there was clearly a need for innovation in technology that was focused on the needs in Africa. That wasn't, let's build a product focused on the US market and then see if we can make it work in Africa, which is essentially what we did with things like HIV drugs. And so that's where Daktari came from. We're trying to develop products specifically for Africa to meet the needs in Africa, the healthcare delivery systems in Africa. And we've just launched our first product, which is a handheld CD4 cell counter. CD4 cells are the test you use to monitor people with HIV. And it was designed and focused and will be delivered exclusively in Africa. I'll just make two observations really about healthcare and the need for technology innovation. So the first one, and I think Joy just alluded to this, the first one is that there's a number of challenges in Africa in delivering high-quality healthcare that don't need new technology, that don't need new shiny baubles or any of the things I just mentioned. They're about business models and service delivery models that can be effective and appropriate and sustained and can make use of the available resources. We also need more resources. You can't innovate your way out of poverty and out of lack of resources. And I think there's a balance to be played there about developing business models and service delivery models for healthcare that make sense, but making sure that more resources are coming into the system, because you just can't deliver high-quality care for no money. So that's the first observation, is it's not always a technology problem, but it can be a business model problem. The second observation I'll make is healthcare in particular has some challenges, different than consumer retail or what Coca-Cola does or software or other things. And I'd just like to highlight two of those challenges. The first one is there are a lot of people who have a hard time looking at companies that make profits off of healthcare. It's easy for people to say, well, Apple makes money or Coca-Cola makes money, but I'm less comfortable making money knowing that what I'm doing is making money off people who are poor and sick. That's true in the US. There are people who struggle with the fact that Pfizer makes money. But it's even more exacerbated and more heightened when you talk about the challenges in Africa. And so it makes it harder, really, to figure out how do you innovate technology when there's a bit of a resistance to say, well, is that going to make money? Is that the right thing to do? We shouldn't be making money off of healthcare. And it just makes the challenge a lot harder when you're talking about really poor people who need these technology innovations and new products, new vaccines. The second thing that's, I think, unique to healthcare is in a lot of the innovation pipeline for vaccines, for drugs, for medical devices, it's incredibly capital intensive. We've raised at Daktari $35 million venture money to get to our first product, and we've been pretty efficient. Typically drugs, it takes $100 million or more just to get a drug to market, often 5 times that much. And for medical devices, it can be hundreds of millions of dollars and at least $50 million in general. And it's, again, a real challenge to say in Africa, we're going to focus just on the products that are needed in Africa, and we're going to go raise $50 million that's going to provide return on investment to investors, because it's a venture-backed effort. And it's much more difficult to do that when it's not clear what the rewards are for the investors. It's clear what the risks are, but the rewards don't seem as great as saying, why don't I just put that money to work for new, cardiac catheters in the US? $50 million is a lot of money. And that's often the starting point. It's often a lot more than that. So I think those are two of the challenges. We need the technologies. There's clear gaps. But doing that in a way where you can build the right products the right way can be difficult. And I'll leave it there.
Good afternoon. It's a pleasure to be here, and really looking forward to the discussion today. I'm Elizabeth Bailey. I'm the director of the Consortium for Affordable Medical Technologies, or CAMTech, which is based at Mass General Hospital Center for Global Health. And CAMTech was launched a little over 2 years ago with a mission to enable and accelerate medical technology innovation for low and middle income countries. And one of the foundational principles of CAMTech is really the importance of co-creation. And consumer products companies figured this out a long time ago. Companies like Nike and Procter & Gamble understood that if you engage your customer in the product development process, you'll end up with products that people like and use. I think if we adapt that to the global health environment, people often debate, who is the end user, who is the customer, and so it could be a patient, it could be a clinician, it could be the Ministry of Health, or a range of other constituents. But however you define the end user, they are in these local environments. They are certainly not here in Boston necessarily, and so. We have some core partnerships that are really critical to our model. We have a strong docking station in Uganda, Mbarara University of Science and Technology, and we have a number of different partners as well in India, clinical partners, academic partners, as well as corporate partners. And so this concept of co-creation, we really extend beyond just engaging the end user in the product development process. We think about co-creating across disciplines. So we bring together medicine, engineering, and business, and really look for technologies that are not only technically innovative and clinically impactful, but also commercially viable, because that's where we'll see the scale and ultimately the public health impact that we're really interested in. And so we really operate at every point along the technology development continuum, from ideation all the way through commercialization. And we kind of kickstart our process with medical technology hackathons. So these are events. We actually had one in this very space just a few weeks ago, where we bring together clinicians, engineers, and entrepreneurs to identify problems, to really work together. We really focus on that cross-disciplinary collaboration. To rapidly iterate, develop prototypes, and then present their ideas at the end of a two-day event. And so people sometimes say, well, what can you really accomplish in 2 days? And as Bill points out, this is really hard. It's hard to develop new products, get them into the market. But we have been incredibly encouraged to see this entrepreneurial enthusiasm from this network of innovators who don't necessarily think of themselves as innovators, but they know their problems, they have interesting technical skills, they can apply business frameworks to these problems, and we sort of describe it as the magic happens really at that intersection. And we had last August, we had our Uganda's first MedTech hackathon. We've done a couple in India, and we're we're gearing up for another hackathon in Uganda later on this summer. And so there is this incredible groundswell of interest in medical technology innovation, but it needs platforms, it needs support to take these ideas forward. So funding is one piece of it, and the venture community, I think, before coming to Camtech, I spent 10 years in the venture capital space. Venture capital is slow, but moving, closer to being able to understand new models of investment. But there needs to be platforms and places for innovators to come and get mentorship and support and technical assistance throughout the process, and it's something that we're certainly working on. But it is, as Bill points out, I think it's a long journey and a hard journey, but hopefully rewarding as well.
Good afternoon, I'm Janine, and I'm with GE. And I want to go back to the foundation of what was brought up in the session about innovation being hope or hype. And so when I think about the two words, of course, I want to go with the word hope, because that's what we all come here and study and go to work and why we do what we do every day. But the reality of this is that I would say it's hope with a very, very heavy chance of discouragement and execution problems and challenges and some defeats along the way. But hope is still the rising word. I believe very much, as we all do, in the promise of technology and innovation, which is needed in Africa. And I think all of us are here to try and think of ways to continue to do that well. And at GE, we have 300,000 employees. Over 40,000 of us, and I say me as well because I am an engineer, are technologists and focus on the science and the technology of how we build better products for the solutions and these tough problems that our chairman, pushes us to come to work each day and try and solve. And about 7 years ago, when we started on this next phase of a journey that was focused on healthy imagination and better health for all people, and that kind of became my next role as default. And we started to think about, can we really provide better health for all people, and how do we do that as a device company that focuses on big solutions? We build big hospitals and big technologies and the Rolls Royce of MRs and CTs, and now we need to sit down and think about reverse innovation and designing things that have a different price point, will impact our P&L very differently because we are a profit-making business, and we have faced that challenge of being nailed to the cross for making money in the healthcare space. But what I find to be most critical is that our chairman, designated a very large fund of money to this initiative and said, let's work on reverse innovation. Let's see what we can come up with. And the technologists at GE, started to build products like our handheld ultrasound, which is, a 390-gram handheld product that can deliver, cardiac, basic ultrasound care, fetal, it does a lot of things that are critical to a space like Africa. And we have spent the past 3+ years training nurse midwives and doing research on their ability to grasp the understanding of basic obstetrics and referral, and to integrate products like this into the communities where we want, or we've been asked to support. And so those are the things that bring us hope. However, the challenge to continue to create and to push our engineers to think and to work in this space, to come up with solutions that we can continue to scale and keep at a relatively low price point, and then also to position ourselves in the global world as a trusted advisor in rural health or low emerging market resource solutions is another challenge that we face as a business, which is why it's so important for us to meet people like each of you who are coming up with ideas and having challenges like we saw in the larger room earlier today, and can help companies like us think differently and do differently. And so I hope that, you know, when we're talking today, you'll challenge us and we'll challenge you, and we'll come up with ways to continue to encourage hope so that innovators like yourself can keep coming with the ideas that we need to try and scale and grow to help the continent that all of us are here to talk about.
Great, thank you all. There's a very terse, clear points to leave plenty of time for discussion. And so I'd like to invite the audience to go up to the mic, and we'll receive some questions. I'll start off the discussion with a question to Joya. One of the things that really inspires me about Partners in Health is the spirit of accompaniment and, you know, your focus on social justice and removing structural violence. It's really hands-on, high-touch approach. And I think about technology. I see my teenager with her iPhone, and I can't get her to talk during the dinner table. And so much of global health is driven by the youth coming up, and they have a fixation for technology. Do you see this enthusiasm for technology diluting your central mission?
I don't. I mean, I really think it's given us more tools to reach more people. So even something as simple as cell phone technology, which again doesn't seem so innovative here in Cambridge, but you know, when I started at Partners in Health 15 years ago, and certainly when we were founded almost 30 years ago, most of the areas we served were not accessible by cell phone. We had to use radios. We had satellite phones that transferred data at 6 kilobytes per minute, and it was impossible to communicate. And now you can pick up a phone and call almost anybody in any of our, with the exception of the country of Lesotho where we work, which is incredibly mountainous and still quite challenging in terms of communication. And often the community health workers that we use are relatively young because we ask them to do pretty hard, you know, manual jobs of walking very far. I mean, they love to be able to communicate with people, with their friends. So I actually think it's helped us a lot, and it provides us enormous tools. I also think for most providers, doctors, nurses, technology is cool. And it is a way to keep them interested in their job. New technologies to look at TB diagnostics, or new ways of looking at X-ray. I mean, it's exciting for them, and it makes it more interesting. And just like for all of us as professionals, the idea of continuing professional development is very important. And I think if we want to keep professionals in their home countries and prevent the brain drain, having access to those technologies is part of the conservation of the sort of intellectual, the intelligentsia in a country.
Good afternoon. Thank you all for your presentations. My name is Senzeni. I am a senior at Yale University. I'm studying biomedical engineering. And my question is directed to Dr. Rodriguez and Janine. Dr. Rodriguez, you mentioned that you have come up with a handheld CD4 counting machine. And I was wondering to what extent GE is working with companies such as yours to foster innovation in healthcare.
First off, if you're going to call her Janine, you should call me Bill, right? So let's start there. So I'm Bill. The short answer is that we actually have a lot of interest from companies like GE. We're not working directly with GE today, but certainly one of the prevailing models in medical device and diagnostic development is startup companies do the early, riskiest phase of technology work, and then larger companies that have a global footprint and know more about manufacturing and distribution then start working with them. And we're into that phase now. So I would say that we've already had a lot of burgeoning partnerships, emerging partnerships with companies like GE, and I expect that will grow over the next few years as we begin to push products into the market. But I'll let Janine comment on her perspective.
You know, from the private sector perspective, PPPs are important to us, and we know that in order for us to continue to penetrate a space, we need partners. What we have often found difficult is to help define what partnership looks like for the people that are approaching us as partners and us as a partner. And so we continue to work through that. We have some very successful partnerships in Africa that we've led, and we've been trying to keep that as local as possible. So our training partner is Ifakar Health Institute in Tanzania, and we do a lot with the ministries and some of the organizations that have offices on the ground where we work. But there are times when, you know, we still have to work through and understand what that is. From an execution perspective, we are such a fast-forward company, and so being able to work in a space where people are already working and then push that along at a different pace is sometimes a challenge for us, so we're still finding that. The other side of that is that we've recently launched a ventures company, and so GE Ventures is and a really cool space, in my opinion, for GE. It's something that's completely out of the box that Sue Siegel, our president of GE Ventures and Healthy Imagination, has brought, and it's in the Menlo Park, California space. And they're partnering and working with various companies, not just healthcare, but across all of our businesses, and looking at partnerships and, you know, how we'll maybe seed some programs or companies and work with them. So I work with the team, I don't work for the team, but I'm really excited that we're even doing something like that. It's a new space, and if you know old school industrial GE, you gotta know this is not, you know, the Jack Welch GE. It's just a very different space, and it's a good place. I'm enjoying it. Not that I didn't enjoy Jack. I worked for him too. That was fine.
Great, thank you. It looks like we didn't have any trouble generating questions. We'll go over to this side of the room and then alternate back and forth. Yes, please.
Hi, my name is Dick Bale, and I'm the president of a small NGO called Communities Without Borders, active in Zambia. In linking this panel to the recent vision talk, the last vision talk about health, youth unemployment, I wonder if any of your activities could feed in and address that problem. I know that Partners in Health, for example, is insistent on paying health assistance, but do you train people to repair medical equipment at GE, or are you helping people to learn how to use CD4 counters? What prospects does this have for helping the youth unemployment issue?
Very quickly for us, from a biomedical engineering perspective, we do have programs in Kenya and a few other countries, Rwanda also, where we've trained several hundred biomedical engineers to train some of our basic equipment. So, you know, that is actually funded through our GE Foundation. They've covered the cost and then provided the training locally, because it's very important, and we're held to a standard from the government for the number of local employees that we can have. I live on the continent, but we have more local employees, obviously, than we do expats.
I'll just quickly, so we're still a small company with 55 people, but we've had over 75 interns, so we have a pretty specific focus on high school, undergrad, graduate, and most of those have been in the States, but about 10 or 12 have been in Africa. And then second, the big win for us in the long run is to have our production facilities and manufacturing based in Africa. Today it's here in the States, but we hope that within 3 to 4 years we'll have most of our facilities and most of our jobs will be local in different parts of Africa.
So last year we had a group called, a consortium called Saving Mothers Giving Life come to our Uganda Hackathon, and they pitched a challenge which was around providing transport in rural areas for pregnant women to get to health facilities to give birth. And a team, kind of this cross-disciplinary model, team picked up the challenge, and they developed a sidecar to a boda or small motorcycle that they manufactured with local materials. And the sidecar itself was really interesting, but what really sort of struck us and some other funders and in the government as well was that there was a business model attached to this, this Bodacart sidecar. And the business model is actually focused on providing microfinance loans to unemployed youth who can buy these sidecars along with their bodas and take not only pregnant women to health clinics to give birth, but also transport bananas to market or transport other things. And so the innovation went far beyond this sidecar, but it really went to this business model identifying a problem and what could be a viable microfinance model to support unemployed youth.
Yes, so very quickly, I would add that a major part of what we do in developing countries is training and education using our own funds. We're not entrepreneurs, but we use technologies that are developed by entrepreneurs, take them to either Africa or Southeast Asia, and help to train health workers on how to detect counterfeit medicines and substandard medicines, which, as you all know, is a big problem in developing countries. So that's becoming a big focus for us, how to protect consumers from bad pharmaceutical products. And we're taking technology into those parts of the world, funding various projects on our own to be able to protect the patient from counterfeit and substandard medicines.
Good afternoon. Thank you all. So far, everything is very good. I've got a question, and I don't know who can handle this or anyone can take this on. So I am in healthcare. I'm actually at Mass General and in the finance world, and I also have a passion for Africa. But the question I have is, given that technology is booming in Africa, are there some opportunities to leverage like telehealth medicine? And then also the other question I have is, I know a lot of people who are in Africa do complain that they can't get good health care, they can't do this. So I'm just wondering, as we're booming and we're thinking of all these other spaces, or sectors, I should say, are booming, can we leverage technology and consider tapping into telehealth medicine or, reaching some of the best doctors elsewhere to sort of bridge that gap?
That's another great question. I think that's, from my standpoint, from our standpoint at Partners in Health, that telehealth is critical to expanding the envelope of services that we can provide for people. I was mentioning the CAT scanner. We don't have a single radiologist in the public sector in Haiti. So all of the radiology is now being read by radiologists all over the United States. And that's all being done, by telemedicine, teleradiology. Now, the goal would be, over time, using those as teaching files to train local people so we won't have to do that forever. We're also doing that with pathology in Rwanda. All of our pathology slides are being read by pathologists here in Boston, and we have trained pathology technicians that can prepare the slides in Rwanda, but we need to. But I think it should be both to provide a service, but also to build capacity over the long run. And again, a technology that can leapfrog over the lack of human capacity and the lack of some of the diagnostic techniques and tools that we have.
Yes, please.
Hi, thank you for your insights. My name is Refilwe, and I'm from South Africa. And I was wondering, for me as a student who is just entering the healthcare industry, it's kind of disheartening to hear so much of the economic standpoint of healthcare and not really the base level of helping people, because I have seen people, whether or not they have cell phones, not being able to have access to the appropriate kind of healthcare that they need. But going on to the economic side of it, to what extent do you think that in order to create a more sustainable continent, we need to have good quality biomedical implements and products and pharmaceutical implements and products be produced in the continent and in each of these individual countries, as opposed to having the West, as it's always been, giving Africa what it needs?
So it's a great point. I wouldn't say that it's always been that way. There's plenty of drugs that are produced locally in Africa, distributed in Africa, and there are a number of successful companies that are doing it. So it's not as though it's all U.S. and European companies right now. I think in the long run, for economic reasons, it's a huge win. More jobs and lower prices, right? That's what happens when you have local activity. So that's really the goal, no question. One of the challenges is to develop the right skill set of entrepreneurs, business managers, engineers. I think the African education system has been less successful to date, and that's where the investment, I think, should go, is let's develop the university system, the high school system, and develop a whole new generation of people who want to do this and stay locally and not leave the country and leave the continent. But in the long run, absolutely, local production, local activity is going to make things much better for everyone there.
Patrick, do you want to talk about
I think the lady was correct. 70% of medicines in Africa are actually imported, imported into Africa. So only 30% of the needs are met by local pharmaceutical companies. Part of the other area that USP is addressing in these countries is to help raise the standard of good manufacturing practices for these medicines, because it's not just about making the medicines on the continent, it's making good quality medicines. And for a very long time, these local companies have not been able to be successful because the quality standards are not quite right, and hence they only have to rely on their local markets. They are not getting business from development partners such as Global Fund, UNICEF, and others, because the quality of the products are just not right. And so as you raise those standards, you make them more competitive so that they are not only catering to the local market, they are also able to make more return on investment by exporting their products outside of their local environment.
Next question, please.
Hi, my name is Nitin Jain. I'm the second-year executive MBA student at MIT Sloan. I've worked quite a lot in the US industry with health IT, and would like to understand what are some of the models that we can take from the US to Africa, primarily around applying like electronic medical record or care coordination. There are use cases like biosurveillance, which are very effective in epidemic tracking and things like that. And the second part I want to know is, what would be an ideal channel for entrepreneurs to go in, and either through collaboration, or what are some of the work happening that we can sort of borrow some of the work from here and launch it there?
I'll just make one comment about your first question. In my experience, when you look at health IT and mobile health, I don't know Asia very well, I don't know South America, but if you look at US, Europe, and Africa, I find what's going on in Africa much more exciting and interesting than what's going on in the US. So I would say there aren't many models I would take from the US and apply to Africa. I would develop them in Africa. That's been my observation and my experience, and that's what we're trying to do with our systems, is work just locally and ignore what's being done in the US.
I would agree, almost stating that, that you have to, come with a completely different mindset, and let's throw the other things aside. But coming in, some of the things that we would challenge you to look at as an innovator is to say, remember scale when you're designing. I think it's important to, be innovative and think about the crazy things and really push against the standards of, well, not the standards, but the thought processes of what would seem to be normal thinking, Western thinking. So push those limits. But it's really, I think it's important to watch what people do, how they do it, and then understand why they do it, because so much of what we do in Africa involves integrating it into the community and getting their full buy-in, or else our products would just sit there and it wouldn't have an impact. And then for us as a company like GE, to consider scale, because when we consider who we're partnering with, if we're taking a partnership from, that's a great idea, and it may have been a great effort in locally, or maybe you can do it in one community, in one village, but when you're asking us to partner to take this thing across the entire Sahara, the costs and the process can get to be quite extensive, and it may change the price points of things, and so we have to look at that broadly when we look at partnering, whether through distribution or as a research partner or something like that.
Next
Hi,
question,
my name is Rakibu Urojabo. I'm from Togo, and I am a cancer researcher here in Boston. I have two questions. My number one question is, as a healthcare provider, when you go in Africa, do you go through the government or you go straight to the community? And if you do go through the government, how does that work? Is it easier for you guys? Because I'm from Africa. I know how hard it is to negotiate with the government. And my number two question is, looking at the business standpoint, when we all know how expensive the drugs are in the state, for instance. Let's say cancer drugs are very skyrocketing in terms of price. How are you able to give the same drug to, let's say, a patient in Africa at a very low cost and at the same time making profit out of it? Because I think one of the problems that drives our local people to go to the black market, sort of like countertop drugs, is the cost. So someone like me has my family down there who gets sick and cannot afford buying the drugs. Why do you do that? Thank you.
So I'll just talk quickly about government collaboration. So my organization, I think we've learned over the last 30 years of working in dictatorships as well as democratically elected governments, that regardless, the only way to really scale an intervention is to work through the public sector, because most NGOs are just too small to really reach everyone, particularly with comprehensive care. So we believe really deeply that to really have a human rights approach, the real right to healthcare, you need two components. One is you need to go to community, engage community, and have community actively participate in the delivery and the implementation of healthcare. But the second is you have to actually help governments to deliver, because most governments of goodwill want to do the right thing by their people, most governments, but they don't have the means. And so we feel that our negotiating power with the government is much greater if we have something that we can offer in terms of technical assistance, in terms of money, in terms of building infrastructure for the government. And so yes, it's complicated, it's slower, but from our standpoint, that's the only way we can really, and if you look at antiretroviral scale, which is now at nearly 10 million people worldwide, and when we all were starting, it was fewer than 50,000 Africans had access, and even those 50,000 were in the private sector only. The only efficient mechanism was a public sector mechanism, and that has been spread throughout Africa and throughout most of the world. So I think it has to happen. Yes, it's more complicated, and it should happen in concert with civil society.
Patrick, do you want to talk about affordability and making a profit?
Yeah, so the question is, how do you make these sophisticated medicines like cancer medicines profitable? I think you can do that in two ways. The most important way, in my opinion, is to create a regulatory environment such that the rogue manufacturers, the ones making the poor quality medicines, don't have their way in the country. I always say that regulation does not hinder good business. Regulation actually creates an environment for good business, because it enables the bad manufacturers, the ones that don't have the right intent of making good products, not survive on that market, because they will be weeded out. So you make the good manufacturers do good business, because you're creating an environment where only the ones that have good intention of making good products are going to survive, and the ones that don't are not going to have the market space to be able to run it well. The other way is generic medicines. I mean, we all know that once a medicine goes off patent, now I work for Pfizer and other innovator companies for a very long time. I know that when products go off patent, the prices drop dramatically, probably by 70%. In developing nations, they should allow or create an enabling environment where generic production can be enhanced. And in some cases, and I'm going to make this remark, I hope I'm not misquoted, I think in the case of critical drugs, countries have to take the stand, perhaps things like compulsory license, where they are able to make those medicines for their citizens and not be bound by intellectual property rights for critical drugs. And when you do that, the prices will come down and they'll become more affordable.
You won't be misquoted. Just quote me if you don't want to get Patrick in trouble. I agree.
Hi, my name is Deeksha, and I'm a physician from India, and I'm studying global health at BU right now. So my question is directed at Bill and Elizabeth. You talked about how important it is to involve venture capitalists, and funding is a big part of healthcare innovations. So to what extent do you feel the private sector has fueled the innovations that we're talking about right now? And if you could give any specific examples.
Just repeat the question. To what extent has the private sector
fueled the innovations that we're talking about?
Boy, that's a complicated question, and it really varies depending on specific products and product lines. I guess the way we think about it and the way most companies think about it is there's various phases of bringing a product from a concept all the way to a product that's on the market. And in the concept phase, which I would define as, can this work? You see a lot of that funded by government grants and by early stage risk-based venture capital. And that's been a pretty successful model in the US. And for relatively low-cost solutions, that model seems to have some traction for the developing world and in parts of Africa. As you get further along from concept to feasibility development, which is taking it from can this ever work to can you make this repeatably manufacturable, work every single time the same way at high quality, it gets a lot more expensive. And I would say the private sector model so far, there aren't a lot of examples of success where the private sector took the risk in a venture-backed model and saw it all the way through to the end. We're trying to be one of those models, but so far there aren't a lot of them. There are some models of the public sector doing it successfully, especially if you look at places like Brazil, Thailand, to a certain extent South Africa. There's been some investment locally by the government in public sector in those early phase, risk-taking phases where you've seen them get all the way through and bring products to market for their local needs. And I think those models there are more of those, but it's not clear that to fill the entire vacuum that needs to be filled with products, I think we're going to need the private sector, which is why we need those models to show that they're successful.
So one of our experiences has been with engaging with a number of the larger medical technology and device companies. And we've heard a real kind of common theme that there is a very strong interest in accessing a new pipeline of products for the African market. But it doesn't fit with, as Janine pointed out, it doesn't fit a lot of these products, even Bill's product, it doesn't fit necessarily with their historical business models. And so because of that, they're looking for a pipeline that has already been de-risked, much more than, say, a company looking to scoop up an early stage technology focused on the US or developed market. And so I think venture capital has a really important role to play, and I think that segment is growing. But I think as early stage entrepreneurs think about that trajectory of at what point might they be picked up or might they partner, they're really going to have to look a lot harder for that risk capital and ways to de-risk their technologies as well as their business models, because I think a lot of these larger companies are looking for that business model innovation in addition to a new product to serve these markets.
Can I just give one concrete example? So there's an American company called Cepheid, and it makes a machine that does diagnostic testing for genes, nucleic acids, for pathogens, for organisms. Cepheid raised $400 million starting in about 1997. And their core focus was to do an anthrax detection machine to be placed in every post office in the US. And obviously they didn't think of that until about 2001, right? Until then it was just we're making a machine. And they built a successful company and they went public, and so they've managed to do that. Well, starting about 10 years ago, the Gates Foundation and a American university started partnering with Cepheid to focus on TB, not anthrax, which globally is a significantly bigger problem. There have, I think, been 4 cases of anthrax in the world. No, not that kind of case.
That's 100 million per case.
Yeah, exactly. So Cepheid successfully, with support from the Gates Foundation, which is a private, it's still private, it's not public, and with support from a university, brought a TB diagnostic to market about 2 years ago. That product has had an enormous impact, and now they're partnering with this government of South Africa, especially, to try to figure out how to get that product to all the mines and all the places in South Africa where TB is endemic and a major problem. And so there's an example, but it's not necessarily one where that's the right model, where you get an American company or a European company to raise tons of money for some American application and then try to move it over to Africa. That happens to be one that worked, but I don't think that's one that's not, to me, the right model.
Hi, Mary Ellen Quasi. I'm an admit for Sloan. I was wondering if you could speak to the role of public-private partnerships as well as cross kind of industry partnerships with respect to the healthcare community. I know that, a lot of the problems that the healthcare community has to face are direct results of things like sanitation. So it makes sense that there might be investment in sanitation or a way to partner with local infrastructure or with other industries that are trying to tackle similar problems, although coming from a different angle. I don't know if any of you have dealt with that or if you think there's a future in that, if maybe there should be some kind of work with other stakeholders that might be facing similar issues but from a different perspective.
So our model has been in countries where we have MOUs, we call them C2Cs, company to country agreements, and it's the corporation of GE and the country. And so in that case, we're partnering across all of the sectors: energy, power, water, healthcare, training, education. And so the full family of GE businesses is agreeing to partner with all of the country's needs. We're trying to make sure that we can touch as many pain points as possible, and that's why the GGO was created, which is Global Growth and Operations. It's the corporate entity of GE overseas, and it means, that's all it means. And so our agreements are signed in some cases like that. And it's not just GE, so it's GE, the ministries, and then any of those partners that we may work closely with, for example, in Tanzania, for healthcare, the work that we do, but we also have an agreement with energy and some of the partners that President Kikwete has asked us to work with on the ground there in energy. So in some cases, we do that. We're doing something like that in Mozambique, as well as in Nigeria and Angola. So a few countries we have that model, and not all of them.
Yes, please.
Hi, my name is Hadi. I'm a graduate student in biochemistry, specialty in neurodegenerative disease. I have so many questions I would like to ask you, but I'm just going to ask one. So my question is directed to all of you. I would like to know, knowing the fact that we said it will be better for the African people to have local industry, and knowing the fact that it's better to feed the person, it's better to teach the person how to fish instead of feeding the person. What is, for each of you, what is something that you can do or something that you are doing now to help those people, those local people, to get those information? Because I can give an example. I'm a graduate student, but I can see how in my country I can help with my degree in biochemistry, because there is a lack of instruments. The only industries that I know are only international industries. I don't know if you understand my question.
I'll lead with that one. I heard a really beautiful analogy just last night, that you can either give someone a fish or you can teach someone to fish, but there's a third option. You can give someone a fish pond. And the reason this is relevant is there's an algae that was created through technical innovation that has allowed Kenyans to create fish ponds and grow tilapia. And there's now more tilapia harvested from commercial fish pond farming in Kenya than all of Lake Victoria. So a technical innovation, a groundbreaking innovation, can actually change the equation and improve access in a way never thought imaginable before. Let me open it up to the rest.
I mean, what we're doing is, so even we're still small, so it's early for us to try to spend money doing this, but we are investing in training programs for laboratory technologists and technicians who are going to become the workforce that support clinical laboratories and clinical diagnostics throughout Africa. So we supported 6 fellowships last year, which wasn't much. We'll do 20 this year to get them training opportunities so they can improve their skills and become more valuable commodities on the local market and get good jobs. That's an example, and really, I said this before, I think what we need to do is invest in education and educational opportunities so you can go back and have a job ready for you, in your home country, and not have to worry about finding something you want to do here as opposed to there.
I mean, I personally am the product of the brain drain. My father left India in 1957 because there was nothing for him to do with a PhD. different now. And I think that's because the government of India, invested in a huge system of universities. And what we see, I think we're trying to link our work at Partners in Health in building capacity with the government's increasing in spending in health. Governments in Africa have promised 15% of their GDP would be spent on health. There's only 2 African governments who have reached that target, the Abuja targets, Rwanda and Zambia, and situations are improving in those countries. And that has to be linked to building higher education so we have a means to keep people in. And this is where I think technology is important, because if you want to maintain the highest level of cadre in your country, you have to provide them technology so that they can do the innovative, interesting things that they were trained to do. So I think countries are moving in that direction, but I think our work has to be linked with an advocacy to build higher education as well as basic sort of education on the ground.
We have lots of more questions. We'll just take one question so we could end at 6.
Thank you very much. Mine is about mental illness and mental health services in Africa. I know I've heard a lot about medical care and medical innovations, but I've not heard any of you talk about, 1% of Africans have schizophrenia, and how does psychiatry and psychology, I'm a clinical psychologist, I had no job to go to in Nigeria, so of course I have my own practice here in the States. My question to you is, what plans do you have to be innovative and creative regarding strategies, to increase the awareness, yes, of mental illness, but also the fact that it's not based on witchcraft, or evil spirit, that is brain science and biology in terms of depression and so on and so forth. So my question is, what can you guys do to help us?
We have a large mental health program in Haiti and Rwanda, and a growing one in Lesotho, mainly because we feel that when you think of healthcare as a basic right, you have to provide the full complement of treatment for the burden of disease. And the burden of mental illness on people in any country, and particularly the poor of the country, is very large when it comes to mental illness. So, but we cannot do that, again, without building capacity, because we can train community health workers to do some basic screening. But the treatment of mental illness requires long-term systems of care. And so we're training psychologists and psychiatrists. And in a country like Rwanda, there's 1 psychiatrist for a country of 9 million people that have overcome a genocide. So we have to actually put together residency programs to train people to do psychiatry. And we're doing that in both Rwanda and Haiti.
Great, thank you. I'd love to take more questions, but I think we've run out of time. I'd like to thank Dominique for putting together just such a wonderful panel with complementary views and expertise, and I'd like to thank all of you for fabulous questions and discussions.